Welcome to Studio A. Our guests today are Dr. Tracy Bellavance and Dr. Lucia Fouts from Women's Health Advantage. We are going to talk about menopause, which, as you know, has been very important to me as I'm going through it right now. And it's something that all women are going to go through at some point in their lives. So sit back and get ready to be informed. We've got two great professionals here. Ladies, thank you very much for coming into the studio today. Dr. Bellavance and Dr. Fouts. Dr. Bellavance, where are you from?
I'm originally from Goshen.
Okay.
Not too far away.
Okay.
I went to Notre Dame for college and then on to Mayo Medical School in Minnesota and then out to Maine for my residency. And at that point, then I wanted to come back closer to home.
Closer to home, to be close to family?
Yeah.
Okay. Mm-hmm. Why did you decide to become an OBGYN?
In medical school, I really liked surgery quite a bit. I can still remember the first time I got to make an incision on a patient. But I also really wanted continuity of care and seeing people throughout their life. Preventive health care I also enjoy too, and OBGYN really fit that bill quite nicely, and I really loved it. I feel very fortunate to have found this calling.
Wonderful. And you, Dr. Fouts, where did you attend school and why did you become an OBGYN?
So I grew up in Cleveland Heights, Ohio, as we were talking about.
Yes.
I came to IU for undergrad, worked for the university for a couple of years after that, and then went to IU for medical school. And my residency was in Louisville, Kentucky, University of Louisville.
Lovely.
So I've been kind of around this bit of the Midwest quite a bit.
Yeah.
Met my husband, though, in Indianapolis, and Fort Wayne was kind of easily between Cleveland and between Indianapolis, so it was a good place for us to land in between.
Yeah.
I started kind of thinking about OB when I first went to an OBGYN myself, and I was having difficulty with periods, you know, the typical high school misery.
Was it endometriosis?
Just difficulty with
Just
periods.
heavy, yeah.
And I remember when I first got treatment for that, I just thought I had died and gone to heaven, and I wanted to help people the way I felt like I had been helped.
An answer to a prayer. Yeah.
But I also really loved the surgical side of things. I think there's a creative aspect to that as well as a diagnostic aspect to that.
Creative in what sense?
Well, if you sew, then you'd know what it's about. But there's something about making things that are untidy tidy again, and helping people feel better that is very appealing. But I also, like Tracy, I wanted to see different ages of people. I didn't want to see them once for a problem and then never see them again. I wanted to have some continuity of care. And
so for both of you, it was important to build that relationship with your...
And both of us probably have patients that we've taken care of the patient and their child.
Oh my
and
goodness.
Their parent and their cousin.
Okay.
So you get to kind of have the family practice perspective on it,
Very
but you get the
nice.
surgical perspective also, which you wouldn't get in any other way.
Very nice.
Yeah.
Very, very nice. So at the time that you both started practicing, was it a male-dominated field? And how did you fare?
When I was in medical school, there were more men than women, but it was starting to become more even. In residency, my residency was quite small and we had quite a number of women, but when I came back to the Midwest, it was still pretty male dominated. And when I joined the group, I was actually the only woman then. But it's really changed over the years. I've been in practice now for...
So you're seeing more women get into the field?
Absolutely, yes.
That's wonderful.
Yeah.
That's wonderful. What about you, Dr. Fouts?
I think when I was in medical school, that was probably the first year that it was about 50-50 in the medical school class. In my residency program, our program director didn't like the possibility that people might go out on pregnancy leave. So he did like to have a certain number of men in each class. But my year was the first year that the whole year was female.
Okay. Wow.
And I think that disturbed him quite a bit, but, it also, we all learned to pitch in for each other and we handled it,
Sure.
So, um, I think he always still wanted to have 50-50 in his classes, but, it felt very comfortable to me. I was very used to a co-ed department, and, I think that's part of why, it was an option when I was looking at jobs to try to find a practice that was all female. I I wanted the mix.
Okay.
I felt like the blend of personality types and genders was good.
Well, something you shared before was that it's more important that you are professional and seasoned
And
than
compassionate.
and compassionate, of course. That was
Yeah.
definitely something you had stated, than your gender.
Yeah.
Yeah. Yeah.
And I
But
think having different perspectives, sorry to interrupt.
no.
I think having different perspectives too can, we each see things in a slightly different way. And it's not unusual for us in our office to take a problem that maybe we've only seen a couple of times or maybe not that often and say, how would you deal with that? And get some perspective on it, whether it's a male or a female, it doesn't matter. The benefit of having,
That
the
insight.
group experience of, 100 years of practice or more
Yeah.
amongst us is useful.
Yeah.
Yeah.
Okay, well, let's get into it, ladies. Let's talk about perimenopause and menopause and postmenopause. Now, Dr. Fouts pointed out something very important about menopause and postmenopause.
Yeah.
And that what?
So I'll tackle what I would say to a patient,
Okay,
if that would be okay.
of course.
So menopause is the process of our ovaries failing, whether that's from being surgically removed or whether they're failing because of nature. Our ovaries only have so many eggs in them. As that population of eggs starts to deteriorate, we start to lose our estrogen, progesterone, and testosterone. And we still may have a little bit of that after the ovaries have quit, but not nearly so much as we had before. That process of the ovaries figuring out when and where to quit is what we'd probably call perimenopause.
Okay.
So people starting to have hot flashes, starting to feel some mood disruption or some cognitive disruption, maybe a little achiness, maybe a little bit of other symptoms, but maybe still having periods and still ovulating,
But just
but having
maybe
some of those
irregular
symptoms.
periods?
Periods can sometimes be a little bit less regular. Typically, they're heavier
Okay.
before we quit.
Okay.
And then what most of us would count as your menopausal, meaning your ovaries have quit, means that you haven't had a period for 12 months.
Okay.
So that's when we can be reasonably sure that those ovaries just aren't going to act back up again and have one more ovulation. They've pretty much given us what they can give us and then they stop, which is different from men. Men, of course, they have testicles, they have testosterone all their lifetime, sometimes a little bit less than earlier, but they don't have that sharp decline. Perimenopause typically can take about 3 years. And then once we're menopausal, and we stay that way.
Okay.
So there's a lot. That's where the confusion, I think, with menopausal and postmenopausal comes in. People think they're two different things. They're just the same, a different word for the same
So
thing.
menopausal and postmenopausal are the same.
They're the same thing.
Okay.
They just mean our ovaries have quit.
Okay.
Yeah.
And perimenopause, when does that normally start? At what age?
Great question. So somewhere between 45 and 55, typically.
45 and 55.
Yeah.
So a 10-year, 7 to 10-year range.
Yep.
Okay. All right. And what can a woman expect during perimenopause? You've shared some things already, Dr.
I'm gonna wait to hear
Yeah.
what you say.
There can be quite a few symptoms, and they may come and go. They may present one, and that disappears, and another one comes.
So brain fog,
yes.
arthritis in the joints?
Well, aching in the joints.
Aching
Maybe
in the
not
joints.
arthritis
Maybe
per
not.
se. It may
Okay.
feel like arthritis.
But it's just aching
yeah.
joints.
I mean, the top symptom And I think oftentimes the first one that comes up is night sweats. I really hear that from patients, even in their late 30s, early 40s, night sweats happening. They may be fine during the day.
Yeah.
Yeah. With that comes sleep disruptions too. 2 o'clock in the morning,
Awake.
every night, waking up, can't fall back asleep until later. And then, of course, they're fatigued, um, sluggish through the day.
Dryness in the skin, dry eyes,
Yeah.
dry lips, dry hands.
Yeah. Yep. That change can come too. The, brain fog, forgetfulness. I think that may be hard to separate, from the lack of sleep. Sleep
Yeah.
is so important
Yeah.
too.
Sleep disruption will cause the
Yeah.
same thing.
Mood changes can happen also.
Let's talk about that. I haven't
Yes.
had that. I've had night sweats, which I'm up every night between 2 a.m. and 5 a.m. Just every night. I'll wake up almost the same time exactly. But anyways, let's talk about mood disruptions. Not mood dis it is
Change.
mood
Yes.
disruptions.
Yes. Yeah.
How does that work? How does that affect women?
Well, what we see, women come in and they may have a range of symptoms. They may say, I'm crying when I don't cry. Things are upsetting me that normally I can handle just fine.
Okay.
Or I'm very cranky with my family, my spouse, my children. I'm not handling things that I normally would.
Okay.
They may feel very angry. They may
Okay.
be depressed. They may be anxious.
Is depression normal, Dr. Fouts?
I think that what I would say I hear is that people who can be prone to depression or have been prone to depression in the past probably feel that a little bit more commonly. I think that it's very hard to sort out the mood disruption, though, from the insomnia.
Okay.
I think when people have sleep disruption, um, it's very easy to feel out of sorts.
Yes.
And for some people, that's anxiety. For some people, that's depression. For some people, that's irritability or easy ability to anger.
Okay.
I think it's very difficult to sort out sleep disruption for many of those other things. And sometimes it's not. You talked about being up for a period of time, but some women, they'll sleep all night long, but they wake up 7 times. Well, any new mother can tell you if she wakes up 7 times at night, she doesn't feel like herself.
Right.
So, um, I don't know if people would say I don't think I hear so much that people feel like it's a major depression, but they feel very much out of sorts and very much not like themselves.
Okay.
And I probably hear a little bit more about irritability than depression.
Okay. All right.
For me.
And let's talk about night sweats. Night sweats is when you wake up and your hair is wet, your pillow is wet, your t-shirt or whatever you sleep in, your tank is wet. And you almost don't know what happened. It feels like somebody threw a glass of water on you and you're just sort of startled waking up and you're just hot.
Yeah.
You're just hot.
Yeah,
What?
so some people will burst into a sweat.
Uh-huh.
Some people will just wake up hot and
Yeah.
kind of gasping.
Yeah.
Many people will say, within 20 minutes of falling asleep, I'm awake again. And I really think that gasping, waking up, overheated,
Yeah.
can create a little bit of anxiety by itself because people learn pretty quickly not to sleep well. And then they get worried about not sleeping, and then you get all the stuff that goes along with that kind of worry in there. And for me, I feel like some of that can be we all like our covers on us, and we all like our flannels, and we all like all these comfortable things.
Right.
But when we're menopausal, we don't have as much ability to control our internal body core temperature. We just don't have the ability to cope as well. So all the things that we pile on ourselves to
when
be
you
comfortable,
first start to sleep.
We're fine when we start to sleep, but then as we heat up, we lose our ability to internally cool, and we just suddenly burst into flame, so to speak.
Yeah.
So if that repeats 7 times a night, that can be a predicament.
Okay.
Yeah.
All right. And so just to have a timeline, perimenopause is about 45 to 55. Menopause lasts how long?
Forever.
Once you're in
Once your
menopause,
ovaries
you're
quit,
in
your ovaries
menopause
quit. Yes.
forever.
Right.
Okay.
So, and perimenopause can be anytime before menopause. Menopause typically happens between 45 and 55.
Okay.
That quitting of the periods
Yes.
and that quitting of the ovaries.
Now, let me ask you, a woman who had had a period for a normal amount of time but was irregular, is it being irregular a normal thing for a woman, or does that mean something is disruptive in her life? Is it a regular and irregularity, is that normal for a woman?
I think that's a big, big question.
Okay.
And I think people can be regular before they become menopausal. People can be irregular for such a huge number of reasons.
Okay.
Before they're menopausal, and I don't think it affects the onset.
Okay. All right. And a woman who, the woman is me. I thought, since I'm being mysterious here, a woman, the woman is me. I had normal periods for a while, and then all of a sudden for about a 3 to 4 year time frame, just stopped having periods. My doctor, Dr. Williams, told me, "Oh, you're going through menopause." And I said, "Well, I haven't had hot flashes or night sweats." And she said, "You lucked out." And then I was visiting a friend in Seattle, and lo and behold, Martha Monthly came back after a 3 to 4 year time frame of not having a period. Now, I will tell you this, at that time, I had lost a significant amount of weight, so that was it.
Yes.
If your weight changes drastically, maybe a 50 to 60 pound weight loss, that can alter your period?
That can, yes. Now, if someone truly is menopausal, her ovaries have stopped functioning,
Uh-huh.
and say that occurred at age 52, and at age 60, she lost a significant amount of weight or gained a significant amount of weight, that will not bring her periods back.
Right.
So if she did have bleeding again, then it would need to be looked at medically.
Okay.
Definitely.
Okay.
Yeah.
All right.
But if somebody has a lapse of periods while they're still not yet menopausal,
Right.
they have a lapse of periods for another reason.
Yeah.
Okay. All right. Okay. Let's talk about stiff shoulder. A lot of women say that they have stiff shoulder during menopause. Have you heard that?
Honestly, I would not say shoulder specifically. I try to remember to tell patients when we're discussing menopause, besides the hot flashes, night sweats, mood changes, sleeping,
Great thought.
that they may notice changes with their joints, aching in their joints. And I very vividly recall when the Women's Health Initiative study came out, was ended early and all that, and all these women abruptly stopped their hormone therapy. How many calls our office got?
Horrible.
HRT.
Because of joint pain.
Okay.
Yes. So joint pain in general, yes, is something that a woman may
It can happen
notice
throughout the body.
Yeah, throughout the
Anywhere.
body.
Yeah.
Okay.
And I think if somebody has a place that's their hot spot, so to speak, they have some arthritis in that place already, then that may be where they notice it more. We talked about before, we have estrogen receptors all over our body.
Yes.
We have them in our skin, we have them in our brains, we have estrogen receptors in our bones and in our breasts, and also in our joint spaces. So when we lose estrogen, we may be more prone to finding changes in any of those areas. I think also sometimes the arthralgia, which is pain in a joint of any location, that can also be partly because of disrupted sleep too. You know, people who don't sleep hurt. So there's a lot of things that kind of can go along with the sleep disruption and not just the hormonal bit of it.
Well, let me ask you, since we've talked about the difficulty in having night sweats, having brain fog, cognitive issues, et cetera, joint problems, what can a woman do? How important is her diet?
I think
I wish it was more important.
yes, it's important. Diet's very important for So many things in general. Yes. Yeah.
Yeah. Well,
So sugars can be inflammatory.
okay.
Caffeine can make people hot flash more. I'm sorry, and can make people more prone to sleep disruption, especially
Alcohol.
caffeine late in the day. Alcohol is a big one.
Yeah.
All those things can matter. Even a little bit of weight loss can decrease the strain on the joints and can help with sleep disruption. Although I wouldn't ever tell somebody that diet by itself is
Well,
for sure going to fix all their
yeah.
woes. It may help things enough that they don't need to do anything else,
Okay.
Yeah.
but it may not be enough.
Okay. All right. So what can a woman do? HRT was something we briefly mentioned, hormone replacement therapy. What do you think about HRT?
I think HRT has a big role in alleviating women's symptoms and improving their quality of life. And that's usually what I focus on if women come in to discuss
Okay.
their symptoms and ask about HRT. I don't think everyone needs to be on HRT. I don't think it's without risk, but I do think there's some benefit. And one of the biggest is quality of life.
And the risk was the heart disease that was heart palpitations, heart problems. What was the issue with HRT and the heart?
Well,
It's the study that you mentioned.
the Women's Health Initiative study, one of the outcomes they were looking at was, does it or decrease the risk for cardiovascular disease? That was, when I was in training and such, we were taught that HRT decreased a woman's risk for heart disease.
Okay.
The Women's Health Initiative study did not show that to be true, but there were also a lot of flaws in the study as it has now come out. I mean, they were treating women of a
all
different,
ages.
of all older ages, really. And women, they were starting women on HRT that we don't typically start women on.
Okay. When would a woman start HRT, Dr. Fouts?
So I feel like for me, my experience has been that the younger the woman comes in with menopausal symptoms, the more likely she's going to be unhappy with any other treatment that I offer.
Okay.
And I mean, Tracy and I probably both do the same thing. We probably talk about, lifestyle changes. To the patient who wants to talk about it, we probably talk about over-the-counters, herbal medications. There are some antidepressants that used at sub-antidepressant levels can help with hot flashes sufficiently that a person feels okay on them. When I would start somebody on hormone replacement is when they have wanted to try those other things and failed them, and that's what they want to do next. It's, of course, always the patient's, job to say, I feel like I need that.
So sort of as a last resort.
It depends. If the patient comes in and says, look, this is horrible. I really don't feel like myself, and especially if they're on the younger side of going through menopause, they're more likely to need it.
Okay.
So I think my answer has to be kind of tailor-made to the patient.
Gotcha.
And what they ask me for. If their goals are to stay off of it, I'm going to try to do, life teaches itself. So I'm going to try to do what they want me to try to do for them.
Okay.
While giving them, this is the thing that's most likely to make you feel better, but I'm happy to stay away from that if that's what you want to do.
Okay.
The study that we just talked about, though, just to mention it, when it came out, the initial study data about halfway through was published inappropriately and suggested more of a risk of breast cancer than there was. When they finally got all those study data published, it turned out there wasn't really probably as much risk as they had initially put out.
There's a small risk between?
Very small.
Okay.
But probably most of the country had gone off their hormone replacement then. And all of us experienced in residency was everybody went crazy and started calling in saying they were miserable.
Because they were fearful of breast cancer.
Because they were fearful. And as we know about, drama in the media, sometimes fears about things become greater than data. But if a patient, that was a long-winded way to get around to saying, I'll offer it to my patient right up front if that's what they ask me for.
Okay.
But if they ask me, what can I do first, then I'll offer them other options.
And you're the same, Dr.
Exactly.
Bellavance?
Yes.
Yeah.
I try to read the patient, just like if we're discussing surgery too. I mean, some patients come in with, I don't want to say an agenda, but
Have ideas.
they have ideas and things they want to do. And
Yeah.
some women I know will never go on hormone replacement therapy. So I will talk about all the other options and things. And other women, definitely want to try hormonal therapy.
Okay.
So,
there are natural ways to go through this process, the menopausal process. Obviously, there are natural ways, homeopathic ways. What would you suggest?
So I won't mention any particular product
Okay.
because I don't feel like that's my job, but at least not unless I'm one-on-one with a
Sure,
patient. But
I understand.
there are some herbal products that can help some women. I find typically the ones with more mild symptoms get through, the initial phases of hot flashes. And I should have said this before, some women will have hot flashes for a little while and then they seem to stop.
Okay.
Hallelujah. They're great. Some women seem to stop having periods and they don't ever have hot flashes, which is really pretty rare.
Okay.
Usually it's the mother of my patient who's really hot flashing bad and doesn't understand why they were not like mom.
Because every woman's body is different.
It's a little different.
Yes.
Yep. We all have different metabolism. We all have different states that we're in. Some women will go through hot flashes for 3 years, 2-3 years, and then they stop. And some women are hardcore and they keep going for a long, long time. It's seldom that I have anybody in their, I'd say, past like mid-70s who's still hot flashing, but
it could happen.
I have one or two. Yeah.
It could happen because you're in menopause the rest of your life.
Right.
Yeah.
So it could happen.
Right.
How long do night sweats last?
That's the same answer.
The same answer. Okay. And
some women, it's a try and see. We wait and see.
Just have to see what your body does.
Yeah.
Mm-hmm. And the waking up at night, the same thing?
Yep.
Okay. So all of the symptoms can last just the rest of your life.
Can for some people.
For some people. And some
usually they don't, though.
Okay.
I'd say that's true.
Yeah.
Normally they don't.
Most of the time they will stop and improve, maybe be rare. For some women, again, it may be that, the night sweats are terrible, but then, that got better, but now their mood is an issue. Yeah. And I think for a lot of women too, if they are really bad and they're persisting, then they will come back and say, okay, I've had enough
This
now.
isn't working.
Yeah.
Yeah. Okay. All right. Let's talk about weight gain. Weight gain is a huge one.
Mm-hmm.
You are maybe 145, 150 pounds, then out of nowhere, you've got this extra layer of fat around the midsection.
Mm-hmm.
What's going on?
We do get asked that a lot.
A lot.
Yes.
I do think part of it is aging, and menopause obviously occurs as women are aging.
Right.
Part of it is lifestyle. Women are not as active. They may be eating differently. They may be drinking more. The body does change. I find it interesting that women may come in and they say, I'm gaining weight because I'm menopausal. Should I go on hormone replacement? But then they will then ask also, if I go on hormone replacement, will I gain weight?
Okay.
And many have that idea.
Right.
And the weight gain is so very complex.
Okay. Meaning that there are a number of factors that lead to weight gain.
So many factors.
Okay.
And hormone replacement therapy, I really don't think is the answer.
Okay.
It's not the simple answer to that.
Right.
If I have someone who is sleeping 4 hours a night and feels miserable and is not able to make good food choices and do some cooking and shopping and do any exercise at all, that will affect her weight. So in that situation, I think, hormone replacement might be helpful, but there's also all these lifestyle things that need to occur.
As a woman ages, Dr. Bellavance and Dr. Fouts, the things that worked in your 20s and 30s are simply not going to work when you're 50, 55, 60. may have eaten a pretty clean diet by and large, but you do notice the weight gain. So you're saying some of it is age related, that as you grow older, you are going to gain a bit of weight. But I mean, what do you do if you've been eating a pretty clean diet and you don't drink, you don't smoke? What do you do?
Well, my perspective / theory on this is that when we talked about we lose our testosterone, our progesterone, and our estrogen.
Right.
I feel like that's the balance between, we have a little bit of each of those things, but probably the balance between them is also disrupted.
Okay.
And I feel like whatever that changes shifts us to a little bit more male pattern to where we distribute our weight. When we have weight more around our hips, women tolerate that better. Their waistlines don't feel as bad.
Right.
They don't feel as bloaty and yucky. There's also some constipation that gets thrown in there with menopause, which is a whole nother subject, but that can make people feel wider around the middle too. There are ways to make people feel like they're 18 again with hormone replacement, very non-standard methods of hormone replacement. I just want to say, and some that are not necessarily recommended because they do have extra risks to them. What most of us prescribe in the office, though, is going to be very standardized treatment, which has very good safety profiles, known large studies behind the safety of what we do. I feel like, so some of it I feel like is the lack of testosterone hits us a little bit harder. We lose muscle mass. Our muscle is our powerhouse for chewing up our calories. I feel like whatever we can do to build muscle, whether it's adding protein or working on toning muscle, those things can help a little bit. I feel like we're more diabetic-like over our lifetime. So the more we can modify our diets to be, a better protein to carb ratio. I know that's pushed a lot in the diets, but it is more of a thing for a menopausal woman than not.
And it works.
Because the insulin resistance piece of it, we become more like a diabetic or an insulin resistant person over time. So the more we can just be savvy to that, the more we can help ourselves with that. And most of us who work hard on diet, it can be so frustrating to deal with this. But sometimes getting a coach, a physical trainer, athletic trainer can be helpful. You have to find somebody who's savvy, though. Just somebody who tells you, keep on pushing it. That they need to be somebody that's not maybe the best approach. You need somebody who's going to look at you and what your heart rate needs to be to burn calories, what you need to tone muscle. A little bit more of a tailor-made approach can sometimes work for people, but it takes a lot of different angles on it. I think. It's not a simple question.
Not one answer.
No, I wish there was.
Okay. All right. Let's talk about, since you both sort of brought it up, Dr. Bellavance and Dr. Fouts, let's talk about protein in a woman's diet, especially when she's menopausal. And let's talk about resistance training, working out with weights. How important is that?
We are finding now, I think, and there's a lot more out there in the media and studies and such saying how important it is, because we do lose the muscle mass and we're also losing bone density.
Yes.
That starts, the loss begins much younger before menopause, but it's accelerated.
In perimenopause, does it begin?
Even in the late 30s.
I think loss of bone is very early on.
Yeah.
Really?
Yeah.
We probably should be telling people to get on some vitamin D.
Is this men and women or just women?
Mostly women. Men have testicles.
Yeah. But it's a sharper decrease during menopause.
Okay.
So it's kind of a slow decline, but then menopause hits and it's sharper for the bone density. So, resistance training does help with maintaining bone density and building it back up. And then also with keeping your tone and muscle mass.
In the 80s, women thought that doing cardio was the best form of exercise, but really it's weights.
I think it's both.
Do you?
I do. I think the cardio helps us burn the calories, but the muscle is the factory through which we push all the energy.
All right.
So I think we need both.
Okay.
And at the same time, this is where maybe a coach is a good idea. You know, many of us can be dealing with some amount of arthritis. It may hurt us to exercise in certain ways and not in others. And finding somebody who's sensitive to that and can listen to that and help us not get into trouble when we exercise it can be useful.
And you mentioned vitamin D. Mm-hmm. How important is vitamin D?
So I tell my patients vitamin D is kind of the funnel through which we absorb our calcium.
Vitamin D K2 and K2?
We're talking potassium or vitamin K. I think you're talking of vitamin K.
K2, yeah.
I don't think that has so much to do with bone strength, but they do get paired a lot because they're both oil-soluble vitamins.
Yeah.
The vitamin D is kind of what we absorb our calcium through. We can only absorb so much calcium in a day.
Okay.
Most people who have enough dietary calcium may not need to supplement the calcium.
So cottage cheese, yogurt, milk.
All of those things.
Kefir or kefir, however you pronounce it.
But we may not get enough vitamin D. Even in states that are really sunny, you can still see vitamin D deficiency. In the Midwest, the prevalence may be about 70 to 80%. So having a little extra vitamin D is not a bad thing. And it's a very well-tolerated vitamin.
Okay. So green leafy vegetables as well.
That has small amounts of calcium, but it's more the dairy products.
Gotcha.
Or you can do the non-dairy milks, like almond milk, soy milk. I tell patients to check the label.
Okay.
Aim for 100% of the RDA, which is 1,000 milligrams of calcium. Mm-hmm. That's pretty close, 1,000 at least to 1,200 really. But it's easy for patients to remember if I say 100% of the RDA. Aim for that at least.
100% of the RDA. Okay.
Yes.
And let's talk about protein.
If you don't mind, I'm going to say one thing about calcium that's important to me.
Please.
Because constipation sucks. I do tell my patients, because I see family doctors look at their bone strength and say, oh, you need more calcium. Most people, if they are constipated on their calcium, they can't absorb any more than they're already taking in. They need to go. They need to back up on their dose.
All right.
We see that a lot.
Okay.
So enough calcium that we can take it in, but not so much that we're constipated.
Okay, that's important. Thank you for bringing that. No, don't be. Thank you for bringing that point up because, I hadn't noted that constipation was an issue for women on menopause. I didn't know that. So I
think it can be.
Yeah. So you just shared something very important. And I also didn't know that once you absorb this certain amount of calcium, that's sort of it.
There are some vitamins that every bit that we take in, we absorb. There are some vitamins and minerals that we could really only absorb so much. And I think that's very individual to the person's GI tract.
Okay.
I have some patients who say, oh, no, I take 2 tablets of calcium a day and I'm fine. And I have some patients who say, I'm barely tolerating the one I have to take.
Okay.
They're probably better off with dietary calcium if they can get it.
Okay. Let's talk about insulin resistance. What is it? First with you, Dr. Bellavance, and then you, Dr. Fouts, or however you want to answer.
Well, insulin resistance is when essentially your body is not using the insulin that you're making.
Okay.
You eat something that has hydrates, it's broken down into glucose, and you're really not able to manage that glucose and use it and store it appropriately.
Okay.
So as our fat percentage goes up, our fat cells lessen our body's ability to be sensitive to our own insulin. So it can become this nasty little chicken and egg issue where if our fat content goes up, we lose our ability to be sensitive to our insulin. Our insulin's goal is to take what we eat and store the sugar component of it as quickly as it can. Sugar gets stored, if the insulin levels are high, that sugar gets stored as fat very quickly.
Okay.
We make more fat, we become less insulin sensitive. We push more insulin out because we're not sensitive to it anymore.
Okay.
So it becomes this hard little
that's what
cycle.
You mean by the chicken and the egg.
Right. All of that happens before our pancreas, which is the organ that makes insulin,
Yes.
says, hey, I can't do this anymore, I'm quitting. And that's what we call diabetes.
Okay. When someone is pre-diabetic, what does that mean?
Same thing as insulin resistance.
Okay.
Yeah.
So pre-diabetic and insulin resistance, same thing.
Pretty much the same thing.
Okay. What can you do to overcome insulin resistance?
You can do lifestyle changes such as weight loss. So if there's, less fat in the body, you may become more sensitive to the insulin you're making. Exercise can also help to modulate and decrease the highs in the blood sugar levels. And then the diet changes too. Giving the body fewer simple sugars, complex carbohydrates, and protein may help to modulate the sugar levels.
Okay, Dr. Fouts.
The same thing. And I would also say some people probably have some component of genetic predisposition to it, and dietary changes are only going to get them so far.
Okay.
So that tends to be on our turf only a small portion of the time. We tend to send most of that to the family doctors. But protecting people from becoming diabetic, if you can, either by lifestyle changes or medication, is important.
And to check your insulin level, that's the A1C, is that correct?
That's actually your average sugars for the 2 months before you got that test done.
Okay.
Sugar sticks to hemoglobin. So that's the HB and the hemoglobin A1C.
Okay.
Or the HG. So sugar sticks to your hemoglobin. Hemoglobin gets turned over every 2 months.
Okay.
So if you checked a person's hemoglobin to see how much sugar was stuck to it, you could get a pretty good guess for how often are they high.
Okay.
Because the person who has highs is more likely to have more sugar stuck to their hemoglobin. So that's what the hemoglobin A1C does, is tells you what their average sugars are for the past 2 months.
Okay.
In insulin, it can be checked with just an insulin level.
Okay.
But some people are told that they're probably pre-diabetic or insulin resistant by their hemoglobin A1C.
Okay.
Because they're not yet diabetic. By the numbers, they're not yet diabetic, but they're higher than they should be for normal.
Okay. What is normal?
Oh, it's different depending upon the assay.
Okay.
I think the cutoff's 5.6 right now. 5.4.
So.
Yeah.
5.6.
It depends on the lab's assay.
Okay. Okay. All right. Let's talk about cholesterol. Let me just state this. I know that when you're not getting sleep, your cortisol level raises. But cortisol is not something that either of you were prepared to talk about today.
So true cortisol disorders are pretty rare.
Okay.
You're going to find it if you Google it on the internet, and I'll get patients who ask me to check it for them, which I don't have a problem with doing.
Okay.
But true cortisol disorders are pretty rare.
Okay.
But what you said is true. If you're sleep disrupted, you can have
cortisol spike.
Probably not spike so much as just a little bit higher level.
Just to raise cortisol. Okay.
But maybe not in an abnormal way.
Okay.
It may not pick up on the lab.
Okay.
Does that make sense?
Yeah.
Okay.
Yeah, it does make sense. It does make sense. Let's talk about creatine and collagen. How important are both of those things for women that are menopausal?
Are you talking about supplements?
Yes.
I'm probably going to be disappointing, but I would say I never tell anybody to take either one of those.
Really?
No. There's a lot on Google that
I am shocked, as you can tell.
There's a lot on Google that's not useful.
Okay.
It's very hard to absorb collagen through your GI tract. It's a humongous molecule, and it gets broken up into little bitty bits in our stomach. So, and there's huge, huge money in selling people collagen supplements.
Okay.
I don't know that I tell anybody that they should take it.
I don't either.
Yeah.
Neither of you.
It's not useful. And it's actually not. We just don't absorb it through our stomachs. You can't absorb it. You can't absorb it through your skin. You can't smear it on yourself and absorb it through your skin. But there's big money in this, so there's also big advertising this.
We just learned something new, kids.
Companies love to prey on people's misery and desperation.
And the same for creatine?
I just don't know that that's a thing.
Okay. What about you?
Same.
Same.
Yeah.
So what about protein powders? Do you think those are helpful? Or same?
I would say each person has to get their protein in however they can do it.
Whether it's
And I think that that's a very individual journey. Some people are very good at that with, if you're a vegetarian, probably protein powders are going to be useful to you and you may mix them in your smoothies or um there's a variety of different ways to get at that, whether it's protein bars, protein powders. Vegetarians usually have a network of people that they learn things from. Whether they get protein through the vegetables they eat. But I think that's a very individual thing. Protein powders can be overdone too. People can get into trouble with them.
I think for the average, woman out there who's not a vegetarian or a vegan, she may not need to do a protein powder.
So try and get your protein through your diet.
She probably is getting enough protein through her diet.
Okay,
Yes.
so is that
unless she is perhaps,
vegetarian or vegan?
Right. Or if she were, very much trying to build muscle and in, some type of activity, weightlifting or something like that, where she is
Okay.
trying to increase her muscle mass. I think
Okay.
Americans in general, though, get plenty of protein.
And Dr. Bellavance and Dr. Fouts, is it true that you should be getting 1 gram of protein per desired body weight? Like if you want to weigh 145 pounds, then your goal is to eat 145 grams of protein. Is that correct?
I think that's going to be a little outside of what I do.
Okay.
I don't think I could speak to specific numbers on that.
Okay. All right.
I would say though, that reading the boxes on the food we eat is really educational, even for somebody who, like me, I think I know what's in something.
Yeah.
Pulling it up and just looking at it and seeing what the added sugars are and what the carbohydrates are compared to the proteins can be very useful.
Okay.
And for instance, I had a patient today who said, well, I don't take in that much sugar. And I said, well, tell me about liquid sugars. And she drinks a Mountain Dew every day. And I said, well, okay, I'm going to have you educate yourself. I want you to read, how much sugar is in that Mountain Dew product. Liquid sugars are pretty much useless in terms of energy. They pretty much become fat right away.
Okay.
So anybody who's seeking to lose weight, they're going to get into trouble with that.
Okay.
They often also, when you take in liquid sugars, you get an insulin spike. Insulin's job is to put sugar into storage. If you're eating food along with that sugar, which is causing an insulin spike, that food gets put into storage.
Okay.
So instead of creating energy, we're creating stored energy. And
because it goes directly to fat.
Yeah. So I think while we have the opportunity to have a lot of protein in our diet, we may not be coming to terms with how the things we eat are affecting us.
Is there such a thing as too much protein?
Yes. You can get into trouble with that.
Okay.
Kidney functions could be altered.
Okay.
Yeah.
Constipation too.
Yes.
Back to constipation.
Back to constipation.
Yeah.
So there is such a thing as too much protein. So that's why you said that normally you believe people are getting it through their diet, enough protein through their diet.
The average American, yes. And from what,
Is that 3 meals a day based upon 3 meals a day?
Yes.
Okay. All right. How important are eggs? I'm seeing a lot about just first of all, that your first meal should be eaten within a half hour of waking up, that you shouldn't have coffee until an hour after waking up, and that your first meal of the day should be heavy protein and savory, a savory rather than sweet breakfast. Like cereal, no good. Oatmeal, no good.
I think it depends upon the cereal. Again, I think reading boxes is essential.
Okay.
I think a lot of people think Fruit Loops is a cereal. My general, sorry to Fruit Loops, I apologize. But I think if it tastes like dessert in your mouth, then it's dessert.
Okay.
And we probably should limit the quantity and frequency that we're eating those things that taste like dessert.
Okay.
I think there are some cereals that try really hard to not be so many added sugars. They try to have more fiber content in their carbs, and they try to have some protein in them. So some cereals can be okay.
Okay.
Reading the boxes is educational.
Okay.
I think if people look at what they're eating, they may find that some oats are okay.
Steel rolled oats
Are a little better.
Yeah.
Yeah. So, and the goal of a diet is to be doable, right?
Right.
So if it's completely soul crushing, it's probably not going to last for long.
Right.
So I always tell my patients, pick one thing, do the one thing only for a month or two. So I generally tell them, pick liquid sugars, work on liquid sugars for a month.
Okay.
Once you feel like you've conquered that for about a month, you don't feel like you crave it anymore, then pick something else. Maybe you eat a lot of pasta. Maybe cut down on the pasta a little bit.
Okay.
Or try a different kind of pasta that has more protein in it.
So make incremental changes.
One thing at a time. I'm big on that.
Okay.
That, some people may be good at whole life changes all at once, especially if they have a scare of some sort health-wise, but I think most people have to have doable changes.
And you're talking about something that's going to last a lifetime. This is a lifetime change. It's not really a diet, it's a lifestyle.
Right.
That's what I'm trying to say.
But there's also a psychological I'm so sorry.
No.
There's a psychological component. We have some addiction with eating, I think most of us.
Yeah.
And if you look at the psychology of addiction, the brain can stop craving something if you give it a month off of that thing. So if you can accomplish 1 month, which most people find I can do that for 1 month.
Yeah.
They may not crave it as much, and they may be able to move on to the next thing.
Okay.
Sorry.
Oh, I was just going to go back to the eggs.
Yeah.
If you have to look at what are your goals. So, if someone is pre-diabetic and concerned about what their blood sugar is, having eggs in the morning, yes, that will be beneficial, for most people in controlling their blood sugar.
Because it satiates you and keeps you from...
Well, it's protein.
Yeah.
And it's less carbs.
Not carbohydrates. So it will not bump the blood sugar up.
Okay.
Now, is oatmeal healthy? Well, sure, it can be. It's a good source of fiber. It's complex carbohydrates. You may put some blueberries in there,
Right.
maybe some milk or almond milk, getting that calcium in there. But is it going to make your blood sugar go up? Probably.
Okay.
If you're not a diabetic, or pre-diabetic, well, okay, you're getting all those other things too.
Right.
So again, it depends on what your goal is and such. But in general, yeah, eggs are good. Good source of protein.
And what about red meat? What do you think about that? Just in moderation?
I think red meat, has pretty good documented history that it's not quite as good for our arteries as the lean meats are, as the fish and the chicken.
Yeah.
But
poultry is
but
chicken.
probably everything in moderation.
Okay. So a bit of red meat every month, but not a whole lot.
I think if it's all we eat, we probably could be in trouble pretty quick.
Okay.
But if it's in moderation, it's probably okay.
Again, in moderation. All right. So let's talk about hair loss in women during menopause. What's going on? Is that again the drop in testosterone or estrogen or progesterone?
Related to the drop in estrogen. I would say not always noticeable in all women.
Okay.
In some more than others, and probably part of that's related to genetics too.
Okay.
But yes, aging with some hair loss.
Okay, that's normal.
Yeah.
Then
it's common. I'd also say as I said before, we become more diabetic-like over time, and if we're pre-diabetic or insulin resistant, we tend to have more of a male pattern to how we do a lot of things.
Okay.
And hair thinning is
one of them. Okay. All right. We've talked about strength training and how important that is. So working out with weights or whatever you're doing. You had also shared that aerobic activity is very important too. What about just walking? How is that?
I think each person has to pick what works for them.
Again.
I think if you take somebody who has arthritis and you tell them they need to go work on a stair climber for half an hour, they're going to be miserable for the next 2 days.
Yeah.
And they're going to be angry and fed up with you. So I think that each person has to figure out what works for them.
Much like the diet.
Right.
Do it in
and it has
small
to feel
stages.
nourishing.
Yeah.
I think I had some struggles with arthritis for a while, and I like to do a little bit of Tai Chi. I'm not I'm not big into it, but that's something when I'm going through problems with aching that I can accomplish, and it doesn't make me down for the count for any amount of time.
Okay.
So for me, that works for me.
Okay.
I have some patients who say water aerobics does well for them, or chair yoga, or I think everybody has to pick something that works for them. If they don't, then they're going to be unhappy and they won't do it at all.
Okay.
So accomplishable is the goal.
Gotcha.
But I think walking has been shown definitely to be beneficial.
Yeah.
You don't have to go out and run or be on a stair climber. That if you're doing it for calorie burning, well, it's not as efficient, time-wise as running is, but it's easier on your joints and it is accessible to most people.
And keeping moving is important.
Yep.
There's very good data that heart disease is higher in people who smoke, but it's also higher in people who sit on a couch for a lot of time. So the keeping moving is important.
Okay.
I think psychologically and physically.
Is there anything that I have left out? I've tried to ask you all of the top sort of pinpoint questions, and I've got to tell you that creatine and collagen one knocked me out of the park. I really, that one really got me. What should women do early on to help them in this process of what is coming, which is perimenopause and menopause, specifically menopause? What can you do to help yourself ease into it? I know taking vitamin D3. I'm assuming taking omega-3s. We didn't talk about that.
In general, I recommend omega fatty acids. If patients ask, should they take supplements or not, I think that is one that has been shown to be beneficial for men and women.
Okay.
For helping to prevent heart disease. It may help some with mood also.
Okay.
And I don't think there's really been downsides to it either.
Okay.
Yeah.
They help a little with constipation too.
Okay.
I think I think there's not much that somebody can do to keep themselves from having menopausal symptoms that distress them.
Okay.
I think that's one of those things we have to find out.
Gotcha.
But I think if we're going to keep our bones strong, the vitamin D is important. I think omega-3s are great for, keeping all those other things healthier. We can get adequate omega-3s probably with a little bit of fish in our diets. It doesn't always have to be a supplement.
Sardines, mackerel, salmon.
Anything we can do.
A fatty fish.
But, flaxseed oil is another source if people don't like fish.
Okay.
I think keeping ourselves from diabetes and prediabetes is the best, we can do for ourselves.
Okay.
But all of us come to making a choice about working on that kind of lifestyle change when we come to it.
Gotcha.
And I think that we just do the best we can.
Okay. One other thing I'd mention is really talking to a woman's physician, of course, or nurse practitioner, whoever they're seeing, about things they may be noticing and getting their opinion on what they might do to help them.
Which was why it was so important for me to have 2 women doctors on. I know that the men could do it as well, but it was just really important for me to have 2 female doctors on. Well, ladies, that is the end of our time. It goes by quickly. Thank you so very, very much. You don't know how important this was to me. I've been talking about this for the last year. I'm working on it for the last probably 4 to 5 months. So thank you so much for coming on, Dr. Bellavance. Thank you.
Welcome.
Dr. Fouts, thank you.
Thanks for your time.
Thank you very much. And thank you for tuning in, and you be blessed.